Patients, we have 2 cases of the endometrial cancer. 2 days tumor board is basis on the endometrial malignancy. Then they have one of the probably one of your resident, or I don't know, probably, and she will give a talk at about 15 minutes or 10 minutes at the end of the session. Am I right? Yeah. Okay.
Wonderful.
I said say.
So maybe I can, if it's okay, introduce my beloved colleagues. I'm so excited to have my partner in gynecologic oncology, Dr. Amy Breger. I will let her say hello.
Good morning, everyone. It's an honor to be here. So thank you very much for the invitation.
Yes, good morning.
Yeah, and I'm also incredibly excited to have Dr. Yeku, one of our wonderful medical gynecologic oncologists who does a tremendous clinical trial work and huge support and collaborator and partner in our patients. Dr. Yeku, would you like to say hello?
Hello, everyone. It's a pleasure and an honor to be invited. Nice to meet you all.
And then Dr. Devins and Dr. Aliva, I see you both together there. We were blessed us with your presence and expertise at the last session, just to say hello.
Hello, everybody. We are also happy to be here, even though we don't have such a beautiful view as Dr. Breger has from her office. But we are excited to be, with all of you.
Great. And then Dr. Vivara Mazina, who is our almost senior gynecologic oncology fellow. She has what, 2 more weeks, Dr. Mazina? And she is going to teach us at the end. Why don't you say hello, Dr. Mazina?
Hi, everyone. I'm very excited to be here, and I was sad to have missed the last session. So thank you so much for having me present today.
So maybe we can turn it over. I think we also have Dr. Burkow and maybe Dr. Philp, our other fellows.
Yes, they're both here. We run into major sound interference if we all try to talk at the same time.
Great. Okay, so I'll hand it back to you, Dr. Shahana.
Thank you very much. Thank you, AK. Now, Assalamu alaikum and good evening to all the Asian colleagues, and good morning to our US friends. And this is the multidisciplinary tumor board. Welcome you all to this multidisciplinary tumor board. Our 2 days tumor board session is the endometrial cancer. It is an initiative of the Mass General Hospital and the Oncology Club Bangladesh. The objective of this multidisciplinary tumor board is to share the expert knowledge and the experience of the advanced and the standard clinical guidelines and the practice through the collaborations of the Oncology Club Bangladesh with the Mass General Hospitals. The Mass General Hospitals, it is established in this 1811 and the has been the obligated as a to deliver the standard, the setting medical care. And throughout this period of the time, the hospital had the continuation of the commitment to advancing that care through the pioneering the research and educating the future healthcare the professionals. In 2008, this Mass General was the registered, the redesigned as the Magnet Hospital in the highest honor of the nursing, and it is the guided by the needs of the palliative and their families, and the Mass General Hospital aims to delivering the best health services and guided and as a safe and the compatible the environment, and to advance the care through the innovative the research and the educating to improve the health and the well-being of the diverse the community they serve. And Oncology Club Bangladesh, it is a platform for the all fighting against the cancer. It is also the founder and the Bangladesh chapter of the SARC, South Asian Federation of the for regional the cooperation, the SARC Federation of the Oncology, the only platform of the oncologist the recognized by the SARC Secretariat. And this platform is founded by the Professor Dr. ABMF Korim in 1996 and was registered by the Ministry of the Social Welfare of the Bangladesh. This organization is moving forward with the aim and objective of the improving the oncological care and the oncological services and the oncological setup. And every year, the Oncology Club, the arranging the Cancer Congress, and the last 2 years, we were unable to arrange this program due to the COVID pandemic. The presenter of the today's session is the resident, that is Dr. Sushmita Sarkar. She is the resident gynecological oncology who is working in National Institute of Cancer Research and Hospital. It is a government tertiary care hospital in Dhaka, Bangladesh. And the panelists today are the Dr. A.K. Goodman. She is the Professor Gynae Oncology Division, and Dr. David. He is the Director Gynecological Cancer Program, MGS Cancer Center, and Dr. Amy Breger, and he is the gynecologic oncologist and the gynecological surgeon in Mass General Hospital. And also Dr. Kimi and all others. The panelists are the Dr. Barbara Majina is also the gynecological oncology department in Mass General Hospital, and the Dr. Jacqueline is the assistant in pathology in Mass General, and also the Esther Oliva is the pathologist in Mass General Hospital, and also the Dr. And we have also the scientific secretary, and under the support of him, we are arranging regularly this program. Dr. F.M. Kamaluddin is the scientific secretary of the Oncology Club, the secretary general of the general, and also our inspirator is that the man is always supporting us, and every day, every program, under the support of him and under the supervision of him, we are continuously doing this program. And in last 2 years, during this COVID pandemic, weekly we have doing this program, and from the first session with the Mass General Hospital in collaboration with the Oncology Club, we are starting the program. And that session, our tumor board was on ovarian cancer, and today we have tried to arrange this on the endometrial carcinoma. And be supporting the fighters, they admiring the survivors and honoring them, and they taken and never ever giving up the hope. And we are again this year, after 2 years, we are arranging the SARC Federation of the Oncology, that is BICC, Bangladesh International Cancer Congress in 2020, an event of the Oncology Club Bangladesh, which will be held in 17 to 18 November 2020 in Army Golf Club, Dhaka. Thank you all. Now I request the chairperson of today's session, the president of the Oncology Club, the Professor Dr. A.M.A. Haisar, to introduce to give us permission and to say something to start the session. Sir, please. Over to you.
Thank you, Dr. Samir. I'm really happy to see our friends from USA, particularly Massachusetts General Hospital, headed by Dr. Goodman, and all the. First of all, I want to beg apology from all the participants for a little misunderstanding from our side. We just overlooked timing. So participants from Bangladesh had to wait about 1 hour. I'm really sorry. I beg apology from all of you. I'm really grateful to all the faculties today. You have spent some time, you're going to spend some time with us and really enlighten us and our participants. So, today's presenter, Dr. Sushmita Sarkar, she will be presenting this. Well, without any delay, I think we should start immediately. Dr. Shana, please do.
Thank you, sir. Thank you very much. Now I request our resident, Dr. Sushmita Sarkar, to present our first case, Dr. Sushmita Sarkar.
Good evening to all. Am I audible?
Yeah.
Can you see my slides?
Yeah.
She's 60 years, postmenopausal for 4 years, normotensive, non-diabetic, presented with postmenopausal bleeding for 6 months. She had no family history of colorectal, endometrial, ovarian, and breast cancer. On pelvic examination, a polypoid growth 2 into 2.5 cm arising from cervical os. Biopsy was taken from the cervix. This is the histopathology slide of cervical tissue.
Dr. Sushmita, would you like our pathologists to comment on this or wait till you are finished with your presentation?
No, you can comment.
Okay, Esther and Kyle?
Now, we were muted not to cause any trouble. So
Yeah, basically here you see a high-grade carcinoma with a papillary configuration. In clinical situations like this, the usual question for us is this truly arising from the endocervix or is this extending down from the uterine corpus? And in this particular case, we see these high-grade tumor cells from these images themselves. You don't see any features of HPV infection, which with these HPV-related adenocarcinomas, you see common morphologic features, such as apical mitotic figures, meaning mitoses that are sort of raised to the surface of the carcinoma cells, and numerous apoptotic bodies. So we're not seeing those here. So from these features alone, we might sort of, and the patient's age, favor this to be coming down from the uterine corpus rather than truly arising in the endocervix.
I think
Perfect.
comment at the end of the session.
So the comment was adenocarcinoma, moderately differentiated papillary type. So as he was saying, these adenocarcinoma, whether from endometrium or endocervix, we have done immunohistochemistry that revealed nuclear and cytoplasmic positivity for P16. Estrogen receptor positive, progesterone receptor negative, cytoplasmic positivity for CK7. More than 8% tumor cells showed nuclear positivity for mutant P53, PAX8 negative, Vimentin positive. So the immunohistochemistry compatible with endocervical adenocarcinoma.
Dr. Devins and Oliva, would you like to teach us a little bit more about the immunohistochemistry?
Yeah, I think in scenarios like this, the IHC can be potentially confusing because you think P16 as a marker of HPV-related adenocarcinomas, but P16 can also be quite strongly positive in high-grade, especially carcinomas of any type, including endometrioid adenocarcinomas. The other thing that is more suggestive of endometrioid here is the positivity for estrogen receptor. Usually, endocervical adenocarcinomas are estrogen receptor negative. So the IHC findings are potentially confusing in this particular case, but I think overall are supportive of more of an endometrioid carcinoma. The other thing too is the mutant pattern of P53 expression, which you more often see in high-grade endometrioids.
Because P53, if really there is P53 overexpression, that's not what you see in HPV-related adenocarcinomas. You can see these in gastric type carcinomas of the cervix, but not usually in the HPV-related tumors. It's a bit strange that PAX8 is negative, but I mean, I wonder, from the picture is difficult to evaluate, and I wonder if the staining actually did work.
Along with other baseline investigation, we have done MRI of pelvis with screening upper abdomen. It is the sagittal view. It's the coronal view. It is the axial view. So they reported endometrial mass 2.2 to 2.3 into 5.5 cm with more than 50% myo invasion along left lateral wall and extension into the cervix. There was no extraserosal extension or involvement of vagina. There was no pelvic lymphadenopathy or ascites. From histopathology and immunohistochemistry, it was endocervical adenocarcinoma grade 2. From MRI of pelvis, endometrial carcinoma with more than 50% myo invasion. She underwent radical hysterectomy with bilateral pelvic and parotid lymphadenectomy on 9th May 2022. These are the histopathological slide of surgical specimen.
And so again, here you can see this high-grade carcinoma in the figure to your right, which has a very similar morphologic appearance to that which we saw in the first image.
I was wondering, maybe Dr. Breger, if I could ask you to comment on the issue of surgical interventions. Are you still here, Dr. Breger?
I am. Yes, I
Okay,
am.
great. Okay, sorry. Of a radical versus a simple hysterectomy. I thought the MRI, Dr. Shushmita, was quite compelling for a very bulky looking uterus. Dr. Breger, what are your thoughts about sort of surgical approach and strategy in the setting?
So it's a really excellent question, AK, and I think historically we have treated, certainly if we weren't sure if this was a cervix cancer or uterine cancer, erring on the side of caution and making sure you're doing the appropriate surgery, which certainly is a radical hysterectomy for a cervical primary cancer, making sure you're getting the parametria and making sure you're getting the upper vagina. There is some thought with an endometrial cancer with deep cervical involvement that doing a radical hysterectomy might buy you out of subsequently needing pelvic radiation, although some of the data would now say that that may not be quite as important, and that the indication for doing a radical hysterectomy is making sure we have negative margins in the setting of an endometrial cancer. So I certainly think it was a conservative and appropriate approach to do a radical hysterectomy in this setting. If you had a patient that you thought for reasons that they might not be able to tolerate a radical surgery, you could feel good about the fact that most data, if this were a uterine cancer and you were able to get negative margins without a radical hysterectomy, that would still be the appropriate and correct surgery. And then the question of, we are privileged to have access to sentinel lymph nodes, which is probably, if we thought this was a uterine cancer or even cervix, we would do here at Mass General.
Thank you so much.
So on section, uterus shows an endometrial polyp extended up to cervix, measuring about 7 into 1 cm. Cavity shows a growth measuring about 2.5 into 2 cm. Histopathological report was endometrial adenocarcinoma grade 2 with more than 50% myoinvasion. LVSI was present, and endometrial polyp was endometrial adenocarcinoma moderately differentiated. Cervix was involved by the tumor extension from the endometrial polyp. 2 out of 12 right pelvic and 2 out of 4 parotid lymph node found metastatic. So immunohistochemistry was done again, and P16 found negative, which was found positive in her initial immunohistochemistry. 70% tumor cells nuclei are positive for mutant type P53. She is 60 years, endometrial adenocarcinoma grade 2, LVSI positive, P53 positive. So what about her adjuvant treatment?
Before we go there, I was wondering if Dr. Oliva or Dr. Devens, if you had any other pathologic comments.
I think I would just say, you know, that papillary morphology that we saw, I just want to make the point that it's not specific for any type of carcinoma. You can see it in endometrioid or serous carcinomas, or even on the surface of endocervical, you know, truly endocervical adenocarcinomas. So it's not a very specific morphologic feature, I guess is what I wanted to say. The P53 mutant phenotype, you know, we didn't see the stain. Usually, you know, for something to be truly, you know, mutant for us, we like to see strong and pretty uniform expression in almost all the cells. Sometimes you see cases where, you know, there's perhaps, you know, increased P53 expression over 50%, but it's a bit, you know, patchy in terms of the strength of staining, and that we would still consider a wild type. So I just want to make that comment as well.
We consider wild type because, I mean, as you well know, P53 is associated with adverse prognosis in endometrial cancer, right? So, I mean, P53 mutation is seen more often or typically in serous carcinomas, and is seen in a number of high-grade endometrioid carcinomas, and by that we mean grade 3 endometrioid carcinomas, which you know, would correspond to approximately 20 or 25% of grade 3 endometrioid carcinomas. Not that sometimes grade 2 or grade 1 endometrioid carcinomas can actually be also P53 mutated, but it would be a much more rare scenario. Just to be on the look of, as Kyle said, you know, that the P53 is truly diffusely and strongly positive to actually make the comment that, you know, would be mutated.
Thank you so much. And having that correlates with maybe a worse prognosis or a increased concern for bad behavior.
It correlates with worse prognosis overall. Yes,
Yeah.
it does correlate with, you know, it may correlate with shorter time to recurrence in, for example, in low-grade tumors, you know, that you don't have any other feature of, you know, of adverse prognosis, and of course in those that are endometrial carcinomas grade 3, those that are P53 mutated basically are put, you know, in the molecular category of these tumors that are P53 mutated with the serous carcinomas, which are the ones that have the worst outcome possible, and they have, you know, great degree of instability, you know, and high copy number alterations.
Thank you. Thank you. So I would love to hear from some of my colleagues, and I know that Dr. Mazzina recently presented her thesis research on risk factors in endometrial cancer, and maybe she can give a few comments. And then I would love to hear from Dr. Yeku about thoughts about adjuvant therapy and any other considerations, especially since she is quite high risk. Maybe start with Dr. Mazzina. Can you share a little bit about your insights about what exactly are we dealing with this 60-year-old woman?
Oh, thank you so much. So in my research, we really looked at slightly different risk factors. But I certainly agree that for this patient, both the lymphovascular space invasion and particularly the P53 mutation make me very concerned about her risk, particularly of developing distant metastatic disease. And so I think that here, using the P53 mutation to think about this patient as potentially falling into the more serous-like category of tumors, and thinking about whether systemic chemotherapy, possibly in conjunction with local radiation therapy, is something that would be helpful in her care.
Thank you. Dr. Yeku, what are your thoughts and insights about next steps for her?
I will certainly echo Dr. Mazina's comments. I think from a medical oncologist point of view, when we see disease in the lymph nodes, we automatically think about it as already being a systemic disease. I mean, some cancers don't play by this rule, but for the most part, when you see the cells in the lymph node, one should be prepared that there's a risk for systemic relapse or systemic recurrence, in which case adjuvant chemotherapy is something that would be recommended during the patient encounter. And at least here in our practice, we would use some sort of platinum-based doublets, typically carboplatin and paclitaxel. And indeed, as Dr. Mazina mentioned, this patient would benefit with a consultation with a radiation oncologist to perhaps discuss what role local radiation might play in terms of mitigating local relapse. Because for these women, we tend to think about their risk of local recurrence and their risk of systemic recurrence sort of separately. And employing modalities or approaches to minimize their risk for both is warranted here. There is some controversy as to which one you give first and how you give it, but certainly this patient would benefit from a discussion and perhaps initiation of some sort of platinum-based systemic therapy and discussion with a radiation oncologist as to the role of radiation. In the United States, we're starting to look more at molecular prognostication. I'm very pleased that you used immunohistochemistry to determine the MSI status, but there are other things that are coming like POLE hypermutation and other mutations that may better help us risk stratify these patients, again, with the eye on reducing the amount of people that we give chemotherapy to. So in the future, very soon, we may be able to prognosticate lower risk patients who might only need pelvic radiation or who might not need any therapy at all. But all of this is sort of up and coming in the future. Thank you.
And I would just echo Dr. Yeku's statements completely and say this is an excellent case to present. So treatment of node-positive endometrial cancer is hotly debated based on what trial you look at and what exactly do you do. So just a really terrific case for us to be discussing.
Actually, just as Amy was talking about lymph node positivity, I was wondering when you actually diagnose metastatic adenocarcinoma, do you also look at if there is isolated tumor cells versus actually bigger disease, micrometastasis or macrometastasis? Just a question just for because again, it may be it may relate to prognosis, right, for those patients.
Any thoughts from the gang? Dr. Yeku, issues of micrometastasis versus
So again, another area sort of rife with controversy. I think in more frail patients or in patients who might be sort of reluctant to take on the burden of systemic therapy, patients who might have a lot of comorbidities, patients in whom we think that their morbidity and mortality might be limited by other medical factors. Some of those women, if they have micrometastases, I might not press as hard in terms of offering chemotherapy. Whereas patients who are younger, fitter, and who I worry about the risk of later recurrences, even with micrometastases, I would balance and discuss the risk and benefit of chemotherapy, and perhaps argue that there may be a chance we're over-treating, but anything we could do to prevent recurrent disease, at which stage we think that it's incurable, that might be an argument that some patients would follow.
Thank you so much. So it maybe in the interest of time, Dr. Shusmita, would you like to give us some follow-up of what you decided to treat this patient with?
So our plan is chemoradiation.
Excellent, excellent. Thank you so much. Are there any other questions, or shall we move to case number 2?
Smita, have you any other
Should I
question?
move? No. My question is,
Yeah.
it is endometrioid adenocarcinoma grade 2. If it is P53 negative, so what would be her adjuvant?
Yeah, so back to the points of Dr. Oliva and the group is that the P53 overexpression or it maybe gives you extra information about prognosis, but at the current time, it doesn't alter our therapy. Our therapy is really very much based on depth of invasion, travel to lymph nodes, and to echo Dr. Yeku and Dr. Breger, we really think about the combination of first combination chemotherapy by itself and radiation to manage those two things, but not really any alteration in our therapy based on P53 at this time. Yeah, great
She
question.
mentioned, did she mention P53 negative? Did you mention P53 negative?
Correct, yeah.
So for P53, either diffuse positivity or absence of staining, so negative staining, would actually be a surrogate marker of saying that P53 is mutated. So what you want to see to make it to be normal, right? More normal is that some cells are positive, some cells are negative, some cells have weak positivity, some cells have a strong positivity. There's a mismatch, a mixture of stuff in there. So it's not a homogeneous either positivity or absence of staining. All right.
Yeah, I have a question. If the P53 here, the LBSI, in this case, if there was LBSI was negative and no lymph node positive and only P53 positive, in that cases, should you not go for the adjuvant treatment? Okay. Endometrioid
Really?
grade 2. Yeah.
Yeah, I would base it on the histopathology and the sort of more conventional prognostic factors at this time.
Yeah.
If you have a grade 1 minimally invasive tumor with negative nodes, but you happen to have a P53 suggestion of higher poor prognosis, you just follow them. We actually just recently discussed this at our internal tumor board, having a patient like that. But we wouldn't add adjuvant therapy in the absence of other factors at this time.
Yeah. So only in depends on P53 positivity, that is more than 70% is positive and no LBSI negative lymph node. In that cases, in endometrioid type of adenocarcinoma, the grade 2 will only follow the case.
Correct. Yeah? Correct. Yes.
Next. Okay.
Should I move to second one?
Yes, please.
She's 9 years prior to living to diabetic hypertensive obese lady. She underwent myomectomy on 29th March 2022 due to uterine fibroid in a private hospital. This is the histopathology slide of myomectomy specimen.
Dr. Devens, you're up.
We keep getting stuck on mute. So here you see what looks like quite a high grade collection of cells forming mostly solid growth, but you can see some vague cording. See how the cells are sort of linearly streaming from the upper right to the bottom left in areas. There's also some vague suggestion of gland formation here. So it looks like a high grade tumor, which from this I would favor to be endometrioid, I would say. Yeah. The only other thing you could consider, when cells start to get really solid like this, is whether you're dealing with what we call a dedifferentiated or an undifferentiated carcinoma. But in those, the cells are usually more discohesive, kind of falling apart, almost like lymphocytes, just sort of singly scattered around. And here you see them forming these, glandular and corded structures. So they're still, acting epithelial. So we would just say it's a high grade carcinoma favoring endometrioid.
Thank you.
So in description said, a malignant tumor composed of sheet-like growths of atypical cells devoid of discrete gland formation. The tumor cells infiltrated into the myometrium, and areas of necrosis are also seen. The tumor is poorly differentiated. The final comment was endometrioid adenocarcinoma. With this report, she came to our hospital. Her two parental aunts having colon cancer diagnosed at their mid-40s. Her bowel and bladder habit were normal. On examination, she was obese, no lymphadenopathy, breasts and thyroid were normal. There was an infected transverse incision scar in the lower abdomen, but no palpable mass. Her histopathology report was reviewed.
Dr. Devens or Dr. Oliva, any comments about this?
This looks very similar to the last slide. So again, you can see some sort of vague epithelial cell formations, but it does look like it's falling apart a little bit more here, which may be just due to fixation, but it still has that epithelial character. So I would still call it, a high grade or a poorly differentiated carcinoma.
Interestingly, the cells are really, small. I mean, the nuclei are uniform, I meant to say. And that would, for example, I mean, when you have a solid growth pattern like this, if you don't, if you don't think that there is kind of clearly trabecular, you may think high-grade serous carcinoma with solid growth pattern, as Kyle mentioned, an undifferentiated or the differentiated carcinoma. For a small round cell tumor, still many of these cells, I think, have too much cytoplasm, doesn't necessarily look like a small round cell tumor, but it's only one picture, so it's hard to know.
MRI of pelvic screening, upper abdomen done, and it is the coronal view. Sagittal view that reported a bulky uterus with endometrial pathology. He reported bulky uterus with endometrial malignancy 2.7 to 3 into 6 cm with less than 50% myoinvasion, right? And internal iliac lymphadenopathy, but no ascites. With the diagnosis of endometrial adenocarcinoma, she underwent staging laparotomy, including THBSO with pelvic and biotic lymphadenectomy in National Institute of Cancer Research and Hospital on 25th April, just after 1 month after her initial surgery. Perioperatively, uterus was found bulky, ovaries found healthy. On cut section, small endometrial lesion near internal os and on anterior uterine wall. Histopathology slide of surgical specimen.
Here you can see at the surface of this slide shows more well-formed glands, what you typically associate with an endometrioid carcinoma. So clearly there's a spectrum here where you have some more well-formed glandular areas like this, and then other areas like what we saw on the last screen, which are solid areas. So those solid areas would indicate a higher grade. more of the same here. So these are kind of the more low grade, gland forming areas, a little bit of papillarity at the surface, which again, you can see in endometrioid carcinomas as well as other types, but this looks endometrioid.
And this is why, sometimes there is a discorrelation between what we diagnose in a curettage specimen and what do we see in a hysterectomy specimen when you have much more tissue to be able to examine.
The report was endometrial adenocarcinoma grade 1 with less than 50% myoinvasion. Cervix was free from tumor. Lymphovascular space invasion was not identified. No lymph node found metastatic. Immunohistochemistry was done.
Oh, it's a PR, yeah. So the ER positivity, you more often see in endometrioid carcinomas than in serous carcinomas of the endometrium, for example, and undifferentiated. The thing here, I guess I want to point out is even though in the hysterectomy, this tumor looks low grade, if you put it together with the prior biopsy, which showed those, sheets and solid growth of cells,
It's more than 5%.
if that solid component was more than 5% of the overall tumor, you think that would push it to at least a grade 2 overall. So sometimes if you don't have access to that prior material, it can be difficult to put that story together completely. But that is something that we try to do here if we can see both specimens. Because, depending on how much that solid component was, this may not really truly act like a grade 1. It might be at least a grade 2. And P53 looks wild type here. You can see, as Dr. Oliva was talking about before, sort of patchy staining of variable intensity. Not every cell is staining. So that's a good example of a normal or wild type P53. You can see here, there's loss. Well, that's interesting. Actually, I think so usually when you have loss of MSH2, which you see in the upper right, you also lose MSH6 because those proteins form a complex. So I suspect that bottom picture is actually PMS2. So there was probably a loss of MSH2 and MSH6 in this case, which is concerning that there's a germline mutation in MSH2, so concerning for Lynch syndrome. There's a chance that it could be a somatically acquired mutation, but it would certainly, make you want to look at that patient's history because you more often see MSH2 and MSH6 loss in patients with Lynch syndrome. Okay, yes, so it was MSH2 and MSH6. Okay, that makes sense.
So I'm just going to put out there just that we have less than 15 minutes left to our time together. And I know that Dr. Mazzina has prepared what is it, Vivara, 10-minute talk for us?
Yes.
Yeah, 10 minutes. So I'm so sorry that we might have to cut short our conversation about this particular case. We can talk more about it on email or WhatsApp. But I wondered if I could, if Dr. Philp is present, I just had a question. So this appears to be a confined cancer. Thank goodness. Luckily, she had a pretty spooky looking quote fibroid that was excised, but the rest of it looks pretty good, and it's a confined cancer. What are your thoughts about adjuvant therapy in this setting? And is there anything else you'd think about that might put her at high risk? Do you think anything about her having a myomectomy first possibly puts her at higher risk for recurrence, or is that not a factor in your decision making? I think you might be on mute.
sorry, so from the final path, if I was reading it correctly, it looked like a stage less than 50% myometrial invasion. They called it grade 1 on the final path. But I know there was this question if it was a grade 2 on the biopsy. And sorry, I don't remember this patient's age, but I assume she's young if she had the myomectomy first.
I was like 39, I think.
So I think based on sort of that pathology that this patient necessarily meets criteria for adjuvant treatment. I actually don't know if the prior myomectomy would, if I would do anything differently about that. I mean, I know that there's concern that we could have had tumor cut through and maybe sort of tumor seeding, but I don't necessarily know of any data that we would use to sort of alter our treatment plans based on that. But I think maybe I would worry a little bit more about this patient having some type of recurrence just because the tumor was disrupted at the time of her first surgery. You know, this patient is young. Her ovaries were preserved? No. You know, I think for patients with endometrial cancer who've had complete surgical staging, I think there is at least some evidence that we can use hormone replacement therapy in these patients safely. I know that everybody feels uncomfortable, especially with her having an estrogen receptor positive tumor. But I think you could at least have a sort of a risk benefit discussion with her about estrogen replacement. I don't know. Does anybody have any other thoughts?
Dr. Yeku, I was wondering with that original myomectomy that showed that wild high grade looking piece of this, does that make you think about adjuvant chemo in her setting, even though it's a confined cancer, or just maybe some local brachytherapy?
Just local, because I think as Dr. Oliver was saying, we tend to go with, you know, we look at all the data we have, but we tend to look at the final specimen where we have more tissue and we can get through more sections. So I think that's something I would discuss with the patient and file away, but I wouldn't necessarily use it as the sole basis for recommending adjuvant systemic therapy. That I'm referring to the DNC that she had. What I will say is that, can everybody hear me okay?
Yep. Yes.
Okay, what I will say is just very quickly, there's a little bit of data that we published and has been shown by a few others that patients who are mismatch repair deficient who undergo brachytherapy have higher recurrence rates. Now, all these studies were retrospective, and I think the GOG is doing a prospective study to look at this, but I will recommend that as good sort of reading for everyone on the group. There are a couple of retrospective studies, one published out of the Mass General, that does show that these women with early stage grade 1, grade 2 endometrial mismatch repair deficient tumors treated with vaginal brachytherapy alone have higher recurrence rates. Thank you.
Dr. Yeku, it would be great if you could send them to me and I can forward them to the group. That's a very interesting information. Thank you. So I'm so sorry, Dr. Shahana. Thank you. But people are going to need to peel off here in Boston to go to surgery very soon. And if I could impose upon your hospitality to maybe shift gears to allow Dr. Mazzina to give us her talk in our last 10 minutes. Maybe she could share her slides.
Sushmita, please stop your share screen.
Thank you so much.
Thank you everyone so much for the opportunity to present today. I will do my best to keep my talk as brief as possible. And I was hoping to present today on the topic of endometrioid carcinoma of the ovary, as this is a bit of an academic project that I've been working on with Dr. Devens and Dr. Oliva, as well as with my mentors in gynecologic oncology. Sorry. I wanted to just start the presentation with essentially like a hypothetical patient. And just very briefly, let's say that this is a recently postmenopausal woman who presented with abdominal pain and on CT was found to have an adnexal mass with an elevated CA-125. She was brought to the operating room and the left adnexal mass was found to be densely adherent to the surrounding structures, and she had a hysterectomy VSO with resection of this mass, pelvic anterior lymphadenectomy, omentectomy, and washing. Now, if we imagine two different scenarios for this patient, in one, the final pathology demonstrates a stage 3C high-grade serous ovarian carcinoma, and then the other scenario, the final pathology demonstrates a stage 2B grade 2 endometrial ovarian carcinoma that's associated with endometriosis, and the patient's also found to have a stage 1A grade 1 endometrial carcinoma. The MMR proteins are preserved in both tumors. Now, if we were to discuss these patients at tumor board, for both of them, we would recommend 6 cycles of carboplatin and paclitaxel with no additional therapy recommended for the minimally invasive low-grade endometrial carcinoma. And the question really is that treatment plan and the overall treatment paradigm appropriate for these two patients? So when we think about endometrial ovarian carcinoma, generally it's much more rare than serous carcinoma and makes up only 10% of all primary ovarian tumors. It's typically diagnosed at an early stage and often associated with and believed to arise from endometriosis. And frequently we do find an associated carcinoma of the endometrium. Now, the immunophenotypes are different when we think about these carcinomas by grade. The low-grade carcinomas tend to have an immunophenotype more similar to that of endometrial carcinomas of the endometrium, whereas high-grade endometrial carcinomas immunophenotypically can be very similar to high-grade serous carcinomas. And again, here, the P53 and P16 are important, as we've talked about in earlier at this tumor board. And then when we think about the molecular biology, we often see somatic mutations in beta-catenin and P10 genes, as well as in the PIK3CA and ARID1A mutations. When we think about the treatment approach, however, despite the fact that there are so many different clinical and molecular differences between high-grade serous and endometrial carcinomas, our approach is very similar, and that is both in the operating room and after surgery when we think about the adjuvant treatment. The staging approach that we take, including pelvic and periodic lymphadenectomy, omentectomy, peritoneal biopsies and washings, as well as adjuvant chemotherapy with carboplatin and paclitaxel, with the exception of ovarian limited low-grade endometrial ovarian carcinomas, is typically identical, as are the recommendations for germline genetic and tumor homologous recombination deficiency testing. So we were interested to know whether at our institution, we saw these same characteristics among patients who are diagnosed with endometrial ovarian carcinomas, and I was hoping to share with you today some of our findings. So in order to do this, we obtained IRB approval and pulled from our archives all patients who had been diagnosed with a primary ovarian endometrial carcinoma over the span of approximately 10 years. And this was subject to our expert pathological review, confirming that the diagnosis was true endometrial carcinoma. And for the purpose of this report, we excluded patients who had synchronous primary endometrioid carcinoma so that we could really understand the risk of recurrence and clinical characteristics of patients as it pertained to the endometrioid carcinoma of the ovary. So overall, we identified 63 patients, and of course, this underlines how much more rare this type of tumor really is compared to serous cancer. And these patients were, the vast majority of these patients were surgically staged, with 65% having undergone pelvic lymph node sampling and 52% having undergone pelvic and periodic lymph node sampling. These were comprehensive surgical staging with the median number of pelvic lymph nodes removed being 12 and periaortic lymph nodes removed being 6. And all of these lymph nodes, every single lymph node that was looked at for these 63 patients were negative for metastatic disease. So the breakdown of the stage, grade, and degree of staging is represented here. So the vast majority of the patients that we have taken care of with endometrial ovarian carcinoma over the past 10 years have been either stage 1A, 1C, or 2. And there were 4 patients who, based on intra-abdominal metastatic disease, were stage 3. The distribution of grades is fairly evenly split between grade 1, 2, and 3. And again, as we discussed, most of these patients have been comprehensively surgically staged. Now, this is a busy slide, but I just wanted to show that when we think about patients by low and high grade histology within endometrial ovarian carcinomas, they really are quite distinct. So patients with low grade endometrial carcinomas were much more likely to be stage 1 or 2, with none of the low grade patients having been diagnosed with stage 3 disease. Whereas the opposite is true, and for patients with high grade, grade 2 or 3 disease, they were much more likely to be stage 2 or 3. 4 of the patients in this group had mental metastases, and these are all of these patients had grade 2 or 3 disease. And washings were positive in 12% of patients with low grade disease and 17% of patients with high grade disease. Now, as we've discussed, we typically recommend germline genetic assessment for patients with all subtypes of epithelial ovarian carcinoma, whether endometrial or serous. In this time span, 28 of the 63 patients, or almost half, actually had germline mutational status documented. And there were only 2 patients who were identified who actually had a mutation identified, one in BRCA1 and one in BRCA2. And their histology is displayed at the bottom part of the slide as Dr. Oliva and Dr. Devens reviewed the pathology for these patients to be sure that these were truly endometrioid and not actually misdiagnosed serous tumors. There were 2 additional patients who did not have a germline BRCA mutation, but had a positive HRG score on tumor analysis. And I think in the interest of time, we'll skip reviewing the histology. So I think just very briefly, what we found was that overall the recurrence rate for our patients with endometrial tumors was quite low. Only 16% experienced a recurrence, and only 4 patients, or 6% of the cohort, died of the disease. So overall, the prognosis for these patients is much better compared to patients with serous carcinomas. And on an analysis of their progression-free survival and overall survival, staging did not impact PFS or OS significantly. So I think what we learned from our own institutional analysis of these patients is that lymph node metastases were not seen. And if we are considering taking a patient back to the operating room to restage them, that may be of low yield for patients with endometrioid carcinoma, whether low or high grade. And although BRCA mutations in homologous recombination deficiency is much less frequent compared to serous tumors, it is not non-existent and may still be worthwhile given the profound impact that these findings have on patients' overall care. And so I think the next question really remains is carboplatin paclitaxel truly the optimal treatment strategy for patients with endometrial ovarian carcinoma when we think about how different these patients seem to be? And I think that question is truly unanswered at this time. And I think that that will be really the focus of future research. So thank you so much.
Barbara.
Yes.
Yes, Kyle and I were discussing, do you know the BRCA positive tumors or patients? What was the grade, the stage, and the outcome?
So I don't know. I can look at it and let you know, Dr. Oliva. I know that one of the patients, for sure, the one had a advanced stage, stage 3C, and she is currently still in remission, but was only diagnosed within the last 2 years, and then and she is on PARP maintenance therapy. The other patient, I don't know her, so I don't remember off the top of my head.
Thank you.
Dr. Messina, that was fantastic. If you're comfortable sharing your slides, I can send them around to the group. And I wanted to maybe ask Dr. Shahana to give some closing remarks. And thank you so much for allowing us to participate in this kind of international tumor board. If you think about it, we are connected between here and halfway across the world. It's really a profound and moving experience to have these deep connections. So thank you so much. We look forward to our next engagement together. Dr. Shahana.
Yeah, thank you. Thank you very much, Dr. Eke. I think we have the participant, our friend, Dr. Bhagyalakshmi Nayak. She's from India, and I request Dr. Bhagyalakshmi Nayak to comment on this, the tumor board. Dr. Bhagyalakshmi Nayak, please. Dr. Bhagya, please. Yeah. Unmute. Mehdi, please unmute Dr. Bhagyalakshmi Nayak. Mehdi?
Favara, do you want to unshare?
Firdaus. Oh, okay. Yeah, she can't unmute. Probably the problem is from her side. So we are very much looking. Yeah.
I think that
Yeah.
has some problems.
Yeah.
Comment.
We are very happy. We are very happy that we are joining this tumor board, interesting tumor board, and I think we can continue this. And if you people, you help us, and the students and all the doctors, our colleagues, as because we are the less participant today, because the many people they participated at our time, that is your time is 7 a.m. That this is the missing information. I think next time it did not happen, and now it is the premier time of the Maghrib from Bangladesh, and some of the participants, they have left for the prayer time, and I think I request the president, the Professor Dr. Heiser, to conclude the session. Sir, please.
It was a nice, excellent evening we spent here from Bangladesh, and possibly a bad morning for the West people. So goodbye, everybody. Bye. Thank you. I'll wait to see you again.
See you again in like 6 weeks, okay? We look forward to it. Okay. Bye.
Bye. Shan, you want to say something? Shan, you want to say something? Please do.
Yes, sir. Sir, yeah, I think we are trying to present the different type of cases. The last time we are presenting the ovarian malignancy, this time the endometrial. I think next time we'll go for either gestational trophoblastia or vulvar cancer or cervical cancer. Then every time we'll try to present the interesting cases. So see you all, and request to all to attend the next session. Thank you.
Thank
Bye.
you.
Thank you, everybody. Thank you, everybody, and bye. Inshallah, we'll meet again. Stop recording and close the meeting.